This is your lecture on biologic response modifying and anti-rheumatic drugs. We're going to do a brief overview of our immunomodulators. Drugs that alter the biologic response to autoimmune and infectious diseases and cancer are called biologic response modifiers. They can either enhance or restrict our patient's immune response to either a disease, stimulate hematopoietic function, or prevent disease. We're going to be discussing two classes of our BRMs, or biologic response modifiers. We have hematopoietic and immunomodulating. There are subclasses of our immunomodulating drugs as well, including interferons, monoclonal antibodies, and our interleukin receptor agonists and antagonists. These are going to be adjunct therapy to cancer treatment as well, in addition to chemotherapy, radiation, surgery, with our immunomodulating drugs. And they're going to work by one of three mechanisms. They're either going to enhance or restore our host's immune system, direct toxic effect on tumor cells that either causes lysis or rupture, and adverse modification of our tumor's biology. Within our immune system, there are two major components to manage the immune system function. We have humoral and cell-mediated immunity. These systems are going to work together to identify and destroy all of the foreign particles and cells within our blood or our body tissues. Within the humoral immune system, the functional cells of this system are the B lymphocytes, also known as B cells. These originate from our bone marrow. The B cells are going to remain inactive until an antigen is identified. Once that antigen binds to the receptors on the B cells, a signal is then sent to those B lymphocytes. They mature and differentiate into plasma cells that then produce antibodies. And we have 5 major types of immunoglobulins within our body. We have immunoglobulin A, D, E, G, and M. Within the cell-mediated immune system, the functional cells of this system are called our T lymphocytes, or T cells. They're called T cells because they mature in the thymus. We have 3 types of T cells. This should be familiar to you from physiology. They're not things that I'm going to be quizzing you on, but things that you should be familiar with understanding how the immune system is going to work with the drugs that we will be discussing. Our first category of drugs that we will be discussing are the hematopoietic drugs. These promote a synthesis of varying degrees of major blood components through growth, differentiation, and function of corresponding precursor cells within our bone marrow. We will not be discussing erythropoietics because those were discussed in chapter 54 with our anemia drugs. We do also have colony stimulating factors and platelet promoting as well. These drugs are going to decrease the duration of chemotherapy-induced anemia, neutropenia, and thrombocytopenia. It's also going to decrease our bone marrow recovery time after a bone marrow transplantation or irradiation. It will also stimulate other cells within the immune system to either destroy or inhibit growth of our cancer cells, also including viruses and fungi. They're going to work together by binding to receptors on surfaces of specialized progenitor cells within that bone marrow. When hematopoietic drugs are going to bind to progenitor cell surfaces, immature progenitor cells are going to be stimulated to either mature, proliferate, or differentiate to become active. We're going to first start with our colony stimulating factor drugs. The first drug that we're going to be talking about is filgrastim or Neupogen. This is a synthetic analog of human granulocyte colony stimulating factors, also known as GCSF. These promote proliferation, differentiation, and activation of cells that make granulocytes. They will also contain some of the same pharmacologic effects as our endogenous human GCSF. They're utilized to prevent or treat febrile neutropenia in patients that are receiving myelosuppressive anti-neoplastic for non-myeloid malignancies. Try to say that 10 times fast. That one's a tricky one. So for those of you that are not familiar with neutropenia, that is a low white blood cell count. When you have a low white blood cell count, you are at a very high risk of infection. So we need to sometimes elevate the white blood cell count to reduce the risk of a severe infection, especially for patients that are already immunosuppressed, because an infection could potentially be fatal. Caveats to using this medication: it must be given before a patient develops an infection. But we cannot give this within 24 hours before or after chemotherapy. So that has to be timed precisely. That is very important. It's also contraindicated if there is more than 10% myeloid blasts due to GCSF stimulating malignant growth of the myeloid tumor cells. It is expected that it will cause a fever, muscle aches. Very commonly, it causes bone pain. This is because it's causing inflammation and release of white blood cells within the bone marrow. So we really do want to educate our patients what to expect. We can also educate them something that would be effective non-pharmacologic interventions, maybe heat, maybe cold, but we can also use Tylenol or acetaminophen to manage that pain. So really important you educate them, because they may not know why all of a sudden they're having severe bone pain. And our next drug, sargramostim or leucine. This too is a synthetic analog of our human granulocyte macrophage colony stimulating factor. This is referred to as GM-CSF. These do have the same pharmacologic effects as endogenous GM-CSF to stimulate proliferation, differentiation, and activation of the cells within the bone marrow. Those then become granulocytes, monocytes, and macrophages. This is indicated for promoting bone marrow recovery after an autologous or allogeneic bone marrow transplant for our patients with leukemia and lymphoma. It is contraindicated in presence of more than 10% myeloid blasts due to GCSF stimulating the malignant growth of myeloid tumor cells. This too can cause fever, muscle aches, bone pain, and flushing. So same principles as with our filgrastim. We want to educate our patients what to expect, and we can inform them you could take acetaminophen or Tylenol to manage that pain, as well as our non-pharmacologic interventions. Our next category we're going to be talking about are our monoclonal antibodies. This is the standard of therapy for our patients with cancer, rheumatoid arthritis, multiple sclerosis, organ transplants, and other inflammatory diseases. It's really great with managing cancer therapy because it's going to target those specific cancer cells and not target the healthy cells. You should be able to identify your monoclonal antibodies by their suffix, MAB, M-A-B. So for example, adalimumab. That's how you can identify a monoclonal antibody. They're synthesized using recombinant DNA technology. Unfortunately, they can also be very expensive. We're talking either hundreds to thousands per dose. So very tricky, especially if this is an effective medication. You're going to be more than likely paying quite a bit out of pocket. It is contraindicated in anybody with an active infection because of immunosuppression. Typically, patients are going to manifest acute symptoms. They can be comparable to either allergies or flu. So if you have a patient that starts complaining of fever and chills, it's going to be due to the effect of the medication. So we don't want to assume that it's solely the effect of the medication. You would still want to do an assessment to make sure that there is no active infection, but you shouldn't start stressing out and worrying that there is an active infection because it's likely due to the medication itself. We can premedicate these patients with acetaminophen or diphenhydramine, Tylenol or Benadryl. If there is a very severe reaction, and we're talking pseudo-anaphylactic, then we would use our diphenhydramine, Benadryl, epinephrine, and our corticosteroids. The first medication we'll discuss is adalimumab or Humira. This works specifically through TNF, tumor necrosis factor, a naturally occurring cytokine that's involved in our normal inflammatory and immune response. So it's going to prevent those TNF molecules from binding to TNF surface cell receptors. It's also going to modulate inflammatory biologic responses that are either induced or regulated by TNF. We utilize this for severe cases of rheumatoid arthritis that don't respond to other medications. We can use this alone or in conjunct with other meds. It all depends. Each patient's going to be very different. We do not use this in patients that have active infections, Crohn's disease, ulcerative colitis, plaque psoriasis, or psoriatic arthritis. Our next drug, belimumab or Benlysta, this was actually the first drug that was approved for treating SLE or lupus. It is a B lymphocyte stimulator specific inhibitor. The most common side effects you'll see: nausea, diarrhea, insomnia, bronchitis, migraines, and pain in the extremities. But the most severe and that can be fatal is anaphylaxis and depression. And this medication is going to be administered through an IV infusion. Our next drug, bevacizumab or Avastin, this binds to and inhibits our vascular endothelial growth factor to prevent new blood vessels from forming in tumors in our body tissues. Very important to note, it can complicate surgical wounds because there is an antivascular component. So if you have a patient who's had any sort of surgery and they have an incision, that needs to be monitored extremely closely, especially because of the risk of immunosuppression. If that wound doesn't heal and becomes infected, that could be very problematic and potentially even fatal. So monitoring surgical sites is going to be extremely important. And not really even just surgical sites, any wound that the patient has, because that's going to coincide with healing. So if there's any open wounds, anything that's open on the patient's body, you need to watch that extremely closely. We do also utilize this in managing metastatic colon cancer, rectal cancer, non-small cell lung cancer, and malignant glioblastomas. This drug also has a half-life of 11 to 50 days. And our next drug, infliximab or Remicade, this is one of the first monoclonal antibodies that works by anti-TNF action. It's also approved to manage ankylosing spondylitis, Crohn's disease, ulcerative colitis, plaque psoriasis, and rheumatoid arthritis. One important thing to note, it is contraindicated in anybody that has class 3 or class 4 heart failure. We do also have a black box warning for TB or fungal infections, so we need to make sure that we're testing the patient before we begin this medication for either active or latent TB. And our last drug within our monoclonal antibodies is our rituximab or Rituxan. This drug is going to bind to the antigen CD20, which is expressed in 90% of our B cells. Then the host immune response will cause lysis of those cells. It's second-line treatment for follicular low-grade non-Hodgkin's lymphoma and managing rheumatoid arthritis. We do recommend to premedicate with acetaminophen and diphenhydramine just to reduce those infusion-related effects. Our last group that we're going to be talking about is the disease-modifying antirheumatic arthritis drugs. These are also known as our DMARDs. They're going to modify the progression of rheumatoid arthritis. They have many components, including anti-inflammatory, anti-arthritic, and immunomodulating effects. That's through the inhibition of cell movement into those inflamed and damaged areas. By preventing accumulation of inflammatory cells, we're going to prevent progression of the disease process. There is a slower onset of action over several weeks, so educating your patient, it's not something that you're going to see an effect immediately, which can be really challenging, especially when they're dealing with a lot of pain. So this is more for management, not for your acute symptoms. They are also differentiated into biologic and non-biologic DMARDs. Contraindications: anybody with an active bacterial infection, active herpes zoster, active or latent TB, and acute or chronic hepatitis B or C. As the nurse, it's very important to do a few assessments as well as educating our patient. We have to assess for any active infections, and that might be something that the physician or healthcare provider is not aware of, and that's our responsibility to make sure that we're relaying. So a thorough assessment is really important, and that's not just a physical assessment, but also making sure we're reviewing the labs and looking at the patient as a whole. We should be looking at the white blood cells in our platelets because of the risk of immunosuppression. This drug Also, the category of our DMARDs, there has been a very high prevalence of medication errors due to the dosing. So people will think this is a daily medication when it's actually only for once a week. So then there is a high risk of overdosing your patients. So not only is it important as the nurse to double check the order, but educating your patient, because they're likely going to be self-administering these medications at home, to make sure that they know the correct not only dosing, but frequency. So if you're only supposed to give this once a week, make sure that you're timing that out correctly. If you're giving this for arthritis, we should always be doing baseline of the patient's musculoskeletal status, pain levels as well before, during, and throughout therapy. Very important, avoid people that are ill or anybody with an active infection. Due to being immunosuppressed, you are at a very high risk, and even something that might seem like a small cold could be fatal. Now diving into the drugs, our first drug, etanercept or Enbrel. I'm sure you've seen multiple commercials for this. They're pretty frequently played. This drug is a recombinant DNA that's derived from TNF blocking drugs. It's going to bind to the TNF blocking interaction with the cell surface receptors. We utilize this for managing rheumatoid arthritis, juvenile arthritis, and moderate to severe plaque psoriasis. And that's what you predominantly will see the commercials for, is plaque psoriasis. Contraindicated in anybody with active infections, again, due to immunosuppression. We should be cautious with patients that have pre-existing demyelinating CNS disorders, heart failure, or hematologic abnormalities. It does also contain latex, so if your patient has allergies to latex, they should not be taking this medication. This is going to be subcutaneous, and the patient will be administering this by themselves at home. So return demonstration and ensuring that they know how to effectively give a subcutaneous injection, super important. Again, we cannot use this in patients with heart failure. And we're going to see an onset in 1 to 2 weeks, and there's a half-life of 72 to 132 hours. And our next drug, methotrexate. This is an anti-cancer drug we utilize for managing rheumatoid arthritis. And in low doses, we can use these in patients with cancer. We only give this drug once a week. It can be PO or subcutaneous. The most concerning adverse effect that you should know is bone marrow suppression. And we should also augment with folic acid. The onset of this is a little bit longer, of 3 to 6 weeks, and it has a half-life of 3 to 10 hours.